today is timing of delivery in fetal growth restriction. And as Aditi has very rightly put, tikde aar and tikde bhi. So we are always caught between the devil and the deep sea. First and foremost, there are few concepts which I would just briefly touch before we actually go to the basic topic. That is the difference between an SGA and FGR. This is crucial to know the difference because the management lines are totally different for both. A small for gestational age is simply a fetus which is constitutionally small with its estimated fetal weight below the 10%. Whereas a fetal growth restriction is also a fetal weight which is less than 10%, but there is a flattening of the growth curve. As if the baby has not been able to reach its genetically determined growth potential. Then added to that, there are problems like abnormal Doppler indices, reduced amniotic fluid volume, and that adds to the morbidity perinatally and mortality as well. Why is it essential to know fetal growth restriction? This is because it is a major cause of perinatal morbidity and mortality. But we are looking at something called as Barker's hypothesis, which says that most of the lifestyle diseases which we get in adulthood are having their fetal origin, like coronary artery diseases, type 2 diabetes. They are all starting because of fetal growth restriction, because of insults to the fetal tissues, and that's how you end up in your 4th decade of life with all these complications. So, it is essential to address this entity right away. The challenge is to continue the antenatal management till an optimum timing of delivery so that we don't have the morbidity related to preterm to add to our already SGA baby. I'll just quickly go through. See, basically SGA fetuses continue to remain small. They are basically constitutionally small fetuses. Whereas in FGR, as I already said, long-term neurological, cardiovascular, endocrinological outcomes are always adverse, and hence we need to address these two. Diagnosis of FGR starting from clinically by symphysiofundal height. We all know, I won't go into the details. 1 centimeters rise beyond 14 weeks of gestation every week. Ultrasonography, we look at biometry, the amniotic fluid, and the Doppler indices. Checking the gestational age is crucial to first and foremost diagnose. Starting from the first sonography, early trimester pregnancy, we know the crown rump length. We could also look at the biparietal and transcerebral diameters. Look at the fetometry as we go through pregnancy. Estimated fetal weight, abdominal circumference, and most important is to assess the fetal growth velocity by the various growth charts. These growth charts are generally already inbuilt into the softwares of our ultrasound machines. We just need to put in the values and have a look and trace them so we don't miss it. Amniotic fluid volumes, a preferable technique nowadays is to find a single deep pocket rather than an amniotic fluid index, but an AFI also serves the purpose very well. In Doppler, we look at the vessels which we are going to map would be the umbilical artery, a PM of the 95th percentile is a red flag. Uterine artery, again a PI above 95th percentile. A middle cerebral artery with a PI less than 5. Mind you, in middle cerebral you will always get low resistance which would be more ominous. Ductus venosus and the cerebroplacental ratio, which is the MCA PI is to umbilical artery PI. The uterine artery, as we all know, it basically depicts placental resistance from maternal side. Umbilical artery actually shows the hemodynamic changes in the course of the disease in the baby. Whenever we are looking at an absent or reverse end-diastolic flow in the umbilical artery, it is pointed that there is almost 70% of the placental vessels are occluded and the perinatal mortality is going to be very high. In the middle cerebral artery, maximum times the baby will have a brain sparing effect, so this would be quite later in the course of the disease. But the PI less than 6th percentile is again a red flag. And ductus venosus. This is a key vessel when we are looking at diagnosing FGR in an early pregnancy. That is anything between 26 weeks, which is the period of viability, to 32 weeks. During this gestation, if you want to find out whether there is an FGR, the vessel you need to map is a ductus venosus. There is something called as an A wave in the DP. An absent A wave is pathognomonic of having a FGR already set in. Then cardiotocography. This is mandatory when you are looking at suspecting a placental insufficiency. In some higher centers, we nowadays have a computer-based analysis which is called a CCTG, which gives you more objective assessment rather than a regular CTG trace, which tends to be a little more subjective. So a CCTG and a DV, these two are crucial for diagnosing early onset FGR. This is the German guidelines, AMWF guidelines for diagnosis of FGR. You may just take a snapshot because it's too detailed and I don't want to go through all the details. Now this would be most important thing on which I'll spend a few minutes. See, the diagnosis of IUGR, basically we do a Doppler sonography. Doppler of the umbilical artery if it is normal. We simply continue to control the scan every 2 weeks and deliver the baby anytime after 37 completed weeks. A Doppler sonography of the umbilical artery shows a PI more than 95th percentile. Do a scan every week, continue till 37 weeks, deliver the baby. Then if there is absent end-diastolic flow, you can do a control scan daily, take the gestation up to 34 and deliver. And if there is reversal of diastolic flow, you have to intervene earlier. That is control scan every day and deliver about 32 weeks. Mind you, during delivery, you have to remember that you deliver in a center where there is an NICU facility. You have given administered antidiuretic corticosteroids as per the protocol which Madam has just told. And you may or may not give magnesium sulfate, that's again a little theoretical. But having a NICU, a good pediatric team in place, and given corticosteroids is what's going to keep you safe when managing such babies. Then again, if you are looking at a slightly more severe form of FGR, we will be looking at a Doppler sonography of the MCA, which will be less than 5th percentile. Please take it up to the gestational age, not more than 37 weeks. For a ductus venosus abnormality or absent A wave, reverse or the reverse A wave, you will get it earlier in pregnancy, and that is the time you need to intervene and terminate. The predictors, so in one shot, is the estimated fetal weight of abdominal circumference below the 3rd percentile, umbilical artery above 95th, uterine artery above 95th, and the cerebroplacental ratio less than 5. The challenge of management here is to avoid fetal lipopxemia and prevent irreversible damage or sometimes even intrauterine fetal death. Also, we have to avoid prematurity and sequelae. The parents must be involved, counseled, written consent taken, and medico-legally explain all the pros and cons of this way or that way of your management protocols. Then there is early onset and late onset IUGR, which again the management is totally different. In early onset between 26 to 32 weeks, you will have a problem with managing because there is severe prematurity and related sequelae. In late onset, problem is with the diagnosis because we are going to have more central cardiovascular adaptation, brain sparing effect. Although the mortality is low, but long-term neurodevelopmental problems will be more in the late IUGR babies. Inpatient or outpatient, again it has to be decided case-wise. There is no fixed protocol. Antidiuretic corticosteroids, magnesium sulfate, oxygen, sildenafil, these are all only research-based theoretical, not proven through any randomized controlled trials. So in brief, if I have to tell, in brief, I am supposed to tell the management how we go ahead with the monitoring of FGR. If it's a small for gestational age, and the estimated fetal weight between 3rd to 9th percentile, normal fluid and normal Doppler, you just do a Doppler of the umbilical artery and MCA every 1 to 2 weeks. Follow the growth charts every 2 weeks, and at 37 weeks plus, you have to terminate. Then, if there are early Doppler changes, you need to consider whether you need to admit that patient, do an inpatient monitoring, give her steroids, do her BPP or NST at least every 3 days, every 4 days, 1 to 2 times per week. Similarly, repeat your Doppler studies and map her growth charts every 2 weeks. If the FGR and umbilical artery was absent or reverse diastolic flow, again same pattern. But if the FGR has abnormal ductus venosus droplets, then you have to be slightly more aggressive in your monitoring and decide upon the optimum timing of delivery. Place of delivery, I won't go into the details, I have already spoken. It needs to be a tertiary care hospital with a well-equipped pediatric NICU. Timing of delivery, again this slide is important. What is important when deciding the timing of delivery is that we have to weigh the pros and cons of prematurity, maternal risks and fetal risks. So there are various parameters which we have to weigh and decide when exactly you want to deliver the baby to give the optimum outcome to the couple. Now, when I am speaking about early onset FGR, the CCTG and the DD form the two most crucial aspects to determine the timing of delivery. In a computerized CTG, we are looking at any type of recurrent, unprovoked and refractory decelerations. This should be a red flag. If there are recurrent decelerations, even in a regular CTG, which you cannot explain, that's a red flag, you need to assess further. And in a computerized CTG, you get these STV, these are short-term variabilities. For 26 to 28 weeks, it would be less than 2.6 milliseconds, and for 29 to 32 weeks. So we are looking at a group of early onset FGR. So this is the short-term variabilities which you would like to look at. Anything less than 2.6, anything less than 3 is again a ominous sign. And in ductus venosus waveforms, if you have any kind of pathological findings, that's definitely a sign that you need to intervene. Point to be noted now, there are late signs, these are all late signs of fetal deterioration. So, by the time you actually pick these signs, myocardial dysfunction, hypotension, failed fetal adaptation mechanisms may already have set in, and you may not be able to get the outcome that you are predicting or expecting. So, this underlies the requirement of an extremely good state-of-art NICU facility. Umbilical artery Dopplers, then now coming to the second part of the FGR, that is about 32 weeks. If it's a reverse diastolic flow, consider delivery anytime up from 30 weeks onwards. Absent diastolic flow, anytime beyond 34 weeks. And increased PI more than 95th in the umbilical artery, you can deliver anytime at near term, that is 37 completed weeks. Similarly, for middle cerebral artery, if you are looking at the cerebroplacental ratio, if you are looking at a preterm setting, MCA is not very useful for you. But if there is resistance is low, then near term, please deliver the baby. Abnormally low CPRs, again deliver the baby near term at 37 weeks. Our Foxy-Figo guidelines, these are the three criteria which we need to look into consideration when deciding the timing of delivery. The gestational age, severity of the fetal growth restriction, and findings of fetal monitoring tests. And of course the maternal factors, whether there is preeclampsia, there are other concurrent medical problems, etc. Timing of delivery with isolated SDA. See, isolated SDAs don't pose as much threat so long as they are not very low in their percentiles. If you are looking at a baby who is like a third percentile, you are anyways not going to have a very good outcome. But anything above 10, you can just go ahead and routinely monitor and then deliver near term. Management of fetal growth restriction. Now, in this, there are normal Doppler findings in and increased pulsatility in the umbilical artery. You simply induce the labor, continuous intrapartum monitoring, and can deliver the child with normal Doppler findings. Increased resistance, again similar pattern. The only times you need to actually intervene with the cesarean section would be an early onset IUGR or an early onset of pathological CCTG and abnormal DD. So it's not that FGR is equal to C-section, you can give a trial with continuous intrapartum monitoring and an C-section. I think this is almost a repetition of what I have been telling you, so through it. There are ICOG guidelines which are in place which say that for monitoring at 24 to 32 weeks, CPR less than 5th centile or absent or reverse diastolic flow needs to be monitored every 2 to 3 days. And above that, they only at 32 till term, at 39 weeks, you deliver if the CPR is less than 5th centile Mind you, these criteria are very important and these should be your markers or markers to decide what you are going to do with your patient. Absent or reversed diastolic flow in the umbilical artery, NCAPI less than 6 centile, uterine artery PI more than 96 centile, spontaneous, repeated, unprovoked decelerations. Mind you, this is again a very crucial factor. Many times we tend to oversee. Ordered biophysical profiles, short-term variability, anything less than 4.5 milliseconds, you need to be more alert. And maternal indications such as oligohydramnios, severe preeclampsia, etc. There was a trial called as GRIDGE trial, that is growth restriction intervention trial. I won't go into the details. What's most important is for us to understand this. See, the conclusion of this trial is that the delay in delivery of approximately 4 days in an early onset FGR can cause neonatal deaths. And the second part is even more important. That 2-year outcome did not support the concept that physicians should improve brain development through delivery before terminal hypoxemia. So there is no role of getting panicked and delivering baby early, thinking that NICU would be a better room rather than the home for the baby, because it has been found that if the insert has to happen, it has already happened before it is actually visible in any of our monitoring criteria. So, whenever we are deciding the timing of delivery, all the other factors have to be taken into consideration rather than only the panic of prematurity and hypoxia. Then there is this one last trial I would like to talk about, that is a truffle trial. This is a trial of randomized umbilical and fetal flow in Europe. They looked at the ductus venosus Doppler in conjunction with a computerized CTG, which shows to be improving long-term infant outcome in FGR babies below 32 weeks of gestation. So this is the ultimate outcome which they have given. Now this is one slide. If anybody wants to take a picture, please take, because this is the Matitarth of my lecture.